present you, I would like to introduce you to our presenter, Gail Arno. Gail is the Director of Care Management for Elder Care Management. She brought her expertise to the team at Elder Care Management in 2010 after starting her career in the aging services field back in 1998 as a family consultant for a local placement agency. As a placement agent, she actively educated and guided a generation of seniors and their families to resources and services available throughout the Sacramento area. In 2020, Gail assumed the position of Director of Care Management, providing oversight and counsel in the growing field of aging life care management. To Gail, equally important to her ability to personally guide families is overseeing the team of care managers that she leads. Gail received a Bachelor of Science in History from UCLA and a Bachelor of Science in Psychology from CSU Northridge. She then completed a graduate certification program in gerontology through CSU Sacramento, where she concurrently completed a 6-class case management course certification. Gail is a California Residential Care Facilities for the Elderly, RCFE, certified administrator, and is a state-approved instructor for RCFE administrators certification courses. Gail is a certified care manager through the National Academy of Certified Care Managers and a member of the Aging Life Care Association. She serves as a board member for Oro Caregiver Resource Center and volunteers for the Alzheimer's Association. And as you will see, she is well skilled and experienced in helping individuals navigate the aging process. And with that, I would like to turn it over to Gail.
Thank you so much, Maureen. Sure appreciate it. Oops, I'm having a little trouble moving my screen along here. Bear with me. My apologies. There we go. Sorry about that, folks. So we are going to talk about navigating emergency room and hospital visits, advocating in that hospital setting. And oh boy, this is a tough one, and particularly difficult right now, I think, as we ebb and flow with this new normal, whatever that might be. It has really been a very frustrating time for everybody, but I think there's light at the end of the tunnel, and we're going to give you some tools, I think, to help you today in navigating, and then hopefully throughout the future as we go through these experiences of having to go visit our emergency room, perhaps be even admitted to the hospital, what to do when being discharged from the hospital. So we'll go full circle here and try to give you some guidance and advice from our perspective. Sadly, or fortuitously, I have some experience, as does my team, in navigating some emergency room visits and hospital admissions and hospital discharges. So we're going to try to share with you some tidbits and some words of advice in that regard. So we're going to talk a little bit about when is it the time to go to the emergency room. And I think this is a critical issue right now, because I think we're hearing, should you go to the emergency room, particularly with the tone of the community right now, the tone of the world. Is it truly an emergency visit? And I think what gets to be so very frustrating is it may be a very emergent visit for you, unrelated to the crisis, the pandemic crisis that we're in. And so you may be put on a back burner, middle burner, or if it is a very serious issue that brings you to the ER, hopefully put right at the front burner for that ER visit. We're going to tell you and talk to you about how to navigate maybe getting to those closer burners so that you can get through this experience as it might be. Talk a little bit about what to bring. And if you're able to get in, and that's a big if right now, what would you bring to make yourself more comfortable and better able to advocate, etc. And then also, what would you bring for your loved one or the individual that you're advocating for? So both really important issues that we want to make sure that we address. I'm going to talk about the COVID-19 pandemic impact right now. Going to talk about expectations. What we want to make sure is that we set the expectations appropriately so you get I wouldn't, I think it would be dangerous of me to say, so you don't get frustrated. I'm going to say, so you don't get more than necessarily frustrated. And there will be some frustrations. Our system is bogged down at this point. And I think even on a good day, our system is at times not fluid. And we have individuals we're advocating for who not only don't feel well, but may have some cognitive issues. And so fluidity is really important. Routine is really important. So I think this is a really good time to kind of set the expectations out there so that you have some tools with which to settle expectations that might get a bit rattled when you're there. What is the treatment going to be? What's the diagnosis? What literature are you going to get upon, leaving? Are you going to get anything in writing? Can you ask for anything in writing? Do you just simply go to your portal? What do you tell families or loved ones or other family members about how the experience went when you don't feel like you've been able to get the information that you want as a result? So we'll talk a little bit about that. What happens if it is an admission, and what does that look like? What to advocate for from that point on, particularly during the admission, during the stay, and then also post-stay. What does that look like, and where do you go from there? And what is that discharge all about? What do you get to ask for, and what will really happen if you are discharged, and what resources are there to follow from that discharge and that hospitalization? So we've got some good meaty subject matter here. So let's get on to it and hopefully give you a few nuggets and a few bits of a few tools so that you can challenge and manage this well. So rule number one, it's always call 911 if it appears to be a life-threatening emergency. We're not diagnosticians. We can't really categorically say, my mom is having a stroke. I need you to come right this minute. What we have are indicators. We have sort of layperson's suggestions and guidelines. You think of the stroke guidelines. Are we getting symmetry in that smile? Can they say a sentence? Can they repeat what your command might be? And if it appears that they're not able to, follow the guidelines we've been given in some assessment along that line, then it is time to call 911. I don't think any one of us, should ever feel that we need to apologize for a call to 911. We are calling out the categoric experts in that emergency. And they are actually, while they're not diagnosticians or equipment necessarily, i.e. CAT scans, X-ray systems, they are really seasoned in looking at a scenario and bringing it to the forefront and saying, yes, I think this meets the proper criteria in our evaluation. So let's take this to the next level and let's get this individual off to the emergency room. If you have symptoms of concern that you feel have carried on further than they should have, are more severe than you are comfortable with, if they bring you an uncomfortable sense of being, then I think a call to 911 and a visit to the emergency room is a really valuable experience. If there's a fall where there's any question of a possible injury, a possible fracture, a possible head injury, falls are tricky in particular because if we don't observe the fall, we really may not be able to assess the situation properly, particularly if we have some cognitive issues. So we may be trying to ask our loved one, gosh, did you hit your head? I don't know. What happened? They don't even recognize perhaps that they have fallen. So to know if they've hit their head and there's a need to scan the brain and the head and see if there's any internal concern, or did you hurt your back? I don't know. Did I fall? I don't know if I hurt my back. So again, if we have a fall where there's any slight question, very worth the while to get the proper equipment, the proper professional to do the full evaluation to see if there's been some sort of damage that's been done as a result of that. And then there's always that abrupt, and I really highlight that word abrupt, onset of confusion or change in someone's mental cognition. Somebody who has some mild confusion, but goes to a very extreme level of confusion in a very abrupt time, a very quick time frame, that needs to be looked at. It's most likely an infection somewhere in the body, because dementia or cognitive challenges don't turn on a dime like that unless there's a catalyst to getting them to turn. So really encourage you, if there is an abrupt onset of confusion or change in a cognitive status, to have that looked at in an emergent fashion. Oftentimes, it can be an infection of the urinary tract. You might say, why would a urinary tract infection impact the cognitive abilities? Well, the urinary tract is connected to the bloodstream, which is connected to the brain. So that infection now, while it may have started in the urinary area, it is now all over the body. We just had an individual who went to the hospital with was pretty alert, had this abrupt onset of confusion, went to the hospital, was very confused, very out of it. And the hospital, he was admitted, and there was an identification of a reaction to medication for the urinary tract infection. And so the infection of the urinary tract was problematic, but the outcome of a new medication that he had not had before had an impact on his cognitive ability. As soon as we got that medication out of his system and changed to a different medication, not only did the urinary tract infection clear up, but also did his cognition. So let the professionals do their job. I understand that you don't want to go and spend idle, valuable time and not get answers. And sometimes that does happen. But here are some good qualifiers for contemplating that emergency room visit, as it might be. What do you bring? Well, we are always huge advocates that you bring someone to advocate for you. Here's the challenge in today's world. Some settings will let you in. Some settings will not even let you in the front door. I know the last visit I had with someone at the emergency room, there's a vestibule area that they were triaging in before you even got to the front desk to sign in. I couldn't even get into the vestibule with my client, with my individual, and was left them in the hands of the initial triage who rolled them into the front desk. I had some workarounds, but my initial reception was not good. Most recently, one of our care managers joined a client at one of the major hospitals here. And what we were able to do is get the family member who is the power of attorney to call the hospital and say, yes, please let this individual in. They will be the one coming and going. We will defer that to their decision-making and their information sharing. So bringing someone to advocate for you is a second set of ears that is hopefully ears that and mind and body that can gather information, can listen, can take notes, can discern, can share information, has a good knowledge of this individual, so that you're a benefit and you're providing good information to the emergency personnel, so we can cut to the chase and not be looking for that background information. Many of you might say, well, my mom is in the Sutter system and we always go to Sutter, so they'll have all her information. They'll be fine. They can just look that up. Let me tell you right now, our ERs are hit very heavy, and you may be in a Sutter system. Someone may come to get you and take you, hopefully, to Sutter, and Sutter may not be taking patients. And so you go over to Kaiser. All the more reason why an advocate could be there. Kaiser can't get to Sutter, Sutter can't get to Kaiser's system. So all the more important that an advocate be present there, so that we can, again, share vital information and make this visit much more beneficial, much more productive, with a much better outcome. You want to bring your pertinent personal information, and we actually have a personal toolkit, and you'll be able to access that through Simone at Del Oro following our presentation here if you have interest in it. Really encourage you, if you are so intrigued, to walk through that experience with that toolkit, complete it and have it with you. You may have already done much of what's in that toolkit, but it's a nice checklist and a nice prompt to make sure that you have personal, pertinent information. You want to make sure that you have either with you in hand POLST, the physician's order for life-sustaining treatment, or the advanced healthcare directives, which are both documents that speak to your loved one's wishes. If the emergency location and the hospital does not have a sense of that in writing, they're going to be turning to you, if you're the decision maker, if you're the power of attorney, and asking you all along the line for direction. Awfully nice to have it in writing, and there are documents to have it in writing. So all the more reason to have that completed, be able to hand it over to emergency personnel, and then just fine tune the wishes as the diagnoses, as the procedures continue on. They'll be able then to fine tune with you what your choices and wishes might be. And we'll give you that information on both POLST and advanced healthcare directives in this presentation, and then also in our toolkit. Really important to bring the current list of medications. I can't emphasize current list enough. It is really important to have an updated list. It doesn't have to be fancy. It doesn't have to be retyped each time. Handwritten, lined out. We discontinued this on this date. We started this on this date is just very, very, very helpful. It allows, again, emergency personnel to somewhat bypass a very prolonged procedure as you walk through. Is she still taking this? Is she still taking that? Oh, when did she discontinue this? A current list of those medications is beyond helpful to the personnel that's trying to really give your loved one their full attention. And then chronic medical conditions. I think one of the frustrating things that we experience as we go to the hospital these days, and I'll tell you that I think hospitals are in a current status of treat them and street them. They really are trying to get people through as quickly as possible. And be reminded that our hospitals currently are really more of an acute care setting. This is not a time to get a new diagnosis. This is not a time to get rehabilitative elements to help you along with your disease processes. This is an emergency room visit and a potential hospitalization to address the issue that brought you in that door that day. I fear sometimes that we see hospitals simply contending with the issue that brought you in the door that day and almost dismissive, that's probably too strong a word, almost non-engaged, I guess, in the other elements that are complementary, unfortunately complementary, to your personal circumstances. So a perfect example of that is someone comes in based on a fall, and we've got an individual who also has diabetes, high blood pressure, and so that's a part of who they are as a human being, and these are potentially chronic issues, and you want to be able to remind the staff at the emergency room, I know we came in for a fall, but let me remind you that my loved one really struggles with orthostatic hypotension or hypertension, or has diabetes. Perhaps their blood sugar was just so low, and that was the reason that they were, they had that fall. Let's look at the whole body as best we can, but I will tell you that will be helpful information, and it may assist the personnel to pinpoint the reason for the visit or the reason for the issue that brought them to them, but they may not contend with those other issues. They may not want to address those other issues, but really helpful to know a very concrete sense of what their current medical condition, or excuse me, what their current chronic medical conditions are, and even a sense of when those became present. Really important to know of any allergies. Of course, at this point, they're primarily looking for medical or medication allergies, tape, latex, medications, etc. But food allergies are important as well. So any known allergies, really very important at this point. Of course, insurance information and current identification always helps that process along, because you will be visited by the admissions, the emergency office, or excuse me, the emergency personnel front desk, and then potentially admissions. So they will need that insurance information, supplement information, and then also any identification mechanisms that will be helpful. Right now, we're talking about copies of vaccination cards, proof of boosters, etc., for both the patient and for the advocate. So don't walk in there and thinking, okay, I've got everything in line for my loved one, but oh, I didn't bring a jacket for myself. I didn't bring my vaccination and booster information, etc. So you need that information for yourself and for your loved one. And then always wise to bring a little bit of warm clothing. It can be quite chilly in those emergency rooms, particularly when you get back into a bay. And I heard, oh, this was so distressing last night as I was listening to the news. And it was the national news, and they actually identified an emergency ambulance rig outside of a Sacramento hospital that said it had waited 8 hours. Yes, folks, 8 hours with their transport for a bed just to get them in the ER and get them assigned to an emergency room bed, because the ER personnel the transport people cannot leave until that proper handoff has been done to the emergency room. So will you be in a hallway where the door is opening at all times and be chilly? We can get blankets, warmed blankets for our client, for the individual being assessed, but I don't want to take those warm blankets from those individuals. So wise to bring some warm clothing, bring your own blanket, bring a water bottle. Careful of giving your loved one water, because there may be a situation in which they shouldn't have anything via the mouth. So you may not be able to share that with your loved one. There may be an emergent need for no intake in that regard. You may want to turn to the side and wet your whistle so you're not bothering the loved one with, how come you can have water and I can't? I really am thirsty. Bring some snacks, bring some reading material potential, bring your phone charger. We're also addicted and connected properly, quite so, to our phones, particularly at that time. So not having a charger could be a real detriment at that point. So just make sure that you've got something, some of these tools to keep you at bay and your loved one at bay. We often try to bring in our iPads or our phones with our clients to distract them, and we'll look at pictures. Many a time I've said to a client, boy, this is an awful long wait, isn't it? Why don't we look at pictures of birds? You are so good at identifying birds, and it's a way to sort of distract them and change the channel a little bit on this frustration that we're having of just sitting and waiting for some progress in that emergency room. So again, some good tips and some good items to bring along as you go forth and try to advocate for your loved one. Here you can see the front and back of our POLST, or the physician orders for life-sustaining treatment. Folks, this is the document of choice at this point. And this document is a document that is done in conjunction with the physician, with the actual client or patient, along with their support systems, particularly if there's some cognitive impairment. I believe everyone should have a physician's order for life-sustaining treatment completed, because it really does become your voice should you not be able to speak for yourself in an emergent situation. It is a succinct, singular page of your wishes, comes based off of your thought process with your advanced healthcare directive, which is a more along the lines of a planning document. The physician's order for life-sustaining treatment is an action document. So you complete this with your physician, and you can see, hopefully it's a little foggy, but it's a tough one to keep to put on a screen like this. You can see this gives you that opportunity to be either a full resuscitation, a full non-resuscitation, and even some interventions or compromises within those two extreme degrees, from full intervention to non-intervention. This is signed by your physician, discussed with your physician, and then typically scanned into your medical delivery system and then handed back to you as the recipient or the responsible party for the recipient of this post. From there, this document should go to your kitchen. It should be somewhere visible in your kitchen. I know it's not pretty. Many of our clients are very bothered by it hanging on the refrigerator, but it should be somewhere in that kitchen. That is the common location that our emergency personnel are familiar with. It should also, copies of it should also be in the hands of loved ones, certainly of powers of attorney, responsible powers of attorney, etc. And this then should go with you to the emergency room as well. You want to try to keep track of the original. It should stay with you. And again, the reason you bring it with you is your medical delivery system will scan it into their system. But let's go back to that scenario where you don't get to go to your medical delivery system emergency room because there's just such a volume of activity, and you get diverted to, maybe you're a UC Davis patient, you get diverted to a Sutter patient, a Sutter system. Having this document, able to hand it right to the personnel that you arrive with at the emergency room, will again eliminate a task that they have to search it down, reach out to UC Davis, ask for it to be forwarded. It's really a good document to have in your toolkit as well. And I firmly believe, as I say, really no matter what age we are, once we hit the age of 18, this is a document that can speak for us and make our wishes known, and make sure that we get the attention and the support that we want as we go through some traumas and issues in our lives. So the COVID-19 quandary, this is really our biggest element. We as care managers are often talking to families about being in crisis. Crisis is no fun. We don't function well in crisis. We sometimes can be poor decision makers in crisis, or maybe not even poor decision makers, but not the best of decision makers, because we're emotional, because we're distraught, we're tired, we're exhausted. So here we are, all in this COVID quandary, as it might be, already in a crisis. So now we add an emergency room visit for an ancillary issue, and we're now in a dual crisis. And so I really implore you to put your ducks in a row and get some big decisions made, get your toolkit together, so that when you are hit with the pandemonium of multiple crises, that you're able to manage this well. It's changing day by day. One day we're able to go in and accompany our clients. The next day we're not able to go in and accompany our clients. One of the things that we do as we try to advocate is let the personnel in the facility, in the hospital, know we're the historian. I know who this person is. This person's pretty confused. I can be of some help. We've often been dismissed and sent to the parking lot to wait, and pretty quickly called and asked to step in because the staff is not having such great luck managing this information or this individual and getting the information that they want. So it's a dynamic situation, changing day by day. I think you always try to get in and advocate the best way you can, but we'll catch more bees with honey. So be firm and have your ducks in a row, have your backup documents so that you can be the best advocate you can be. Ask what the hospital's current policy is and see if you can negotiate within that current policy. Again, I sadly say that I think the policies are being changed day to day, minute to minute, and I even find, to be honest, shift to shift. We get some, gatekeepers who are much more severe on certain shifts, and we find that there's some gatekeepers who have some empathy and may not be as committed to the policies, or maybe as informed to the policies and have a little bit more understanding of your position. If you cannot accompany your loved one, if you're not able to get in the door, stay in strong contact with that emergency department. Get the physician's name. Who is being assigned to my loved one? So you'll get an emergency department physician assigned to that loved one to triage them and work with the nurses and the nurse practitioners and the physician's assistant. But get that name so that when you phone in, you're asking for a specific person. Get the phone number of the front desk, the nurse's station. How do I get through to somebody? Give staff your contact information. This is who I am. This is what I do for that individual. This is how you get hold of me. I'll be out in the parking lot, or I will be, sitting here in the seats where you've allowed me as you take her back or him back. Let them know who you are, where you are, and how you can be reached. Again, provide that current medication list and that information list to them, letting them know you want it back. And we really encourage you for a short while, at least, to stay in that parking lot, see what's going on, get a sense of any timing, any opportunity that you might have to get in that door. Or if you feel, okay, they're adamant, they're not going to let me in at this point. If that's the case, then you may want to head home and again, make sure that you're monitoring the situation. You've got phone numbers, you've got names, you know who you're going back to contacting when the time comes. And we all know that it's very much a hurry up and wait situation. Phoning every 20 minutes is probably going to do nothing but irritate and add to the workload of the staff that you're dealing with. So, set your timer, give them a little time to go through things, but don't be shy about monitoring the situation as best you can. Thank them frequently for what they're doing, and see if you can't get them to afford you a little bit of information that should be helpful to you. This is where this written plan, these written bits of information, such as a copy of the pulse, a copy of the advanced healthcare directive, a copy of the current med list, their insurance information. If you're going to put that all together, you might put your contact information in writing as well. You know that oftentimes all of your documents are being moved along as your loved one's being moved along. So who may have the documents may not have gotten to the most current nurse who's been assigned to your loved one. And so getting that in writing, that way they'll know for sure how to contact you as they have questions and concerns about what the next steps might be. So again, this is the biggest quandary we're facing, and I'm sorry we're facing this. It's a day-to-day struggle. And I wish I could change that for you. If I could, I would. I think just keep yourself gathered and continue to be that strong, pleasant advocate that you can be for your loved ones. So what happens when you get there? Let's say you do get in. There are going to be some wait times. And again, I wish we had a system that would really work better for us in that regard. But part of going to the emergency room is waiting. And so this all the more reason why maybe some earphones might be helpful, and play some calm music for your loved one. Maybe again, the iPad so that you can distract with pictures of the beach, or pictures of travels, or pictures of family, so that you can distract that individual. But please walk into it with an expectation that there will be some wait times. You will initially get triaged for whatever is the emergent issue that brought you to the emergency room for this visit. And they will make their own determination as to what is emergent and what is not. So your loved one may say, but why are they going in and we were here ahead of them? Well, they're going in and going back because their situation appears from the professionals to be the more emergent situation in that regard. So they'll triage, they'll take a look at, they'll gather some information right from the get-go, try to discern what the greatest concern is, and then get working on and addressing that greatest concern. They'll be assessing, they'll be asking questions, they'll be determining really what the potential issue is right at the moment. And there may be a lot of individuals coming at you at that time. I know my experience has been you typically have someone who's scribing so that the professionals, there are people who are sitting at the computer taking all this information in. There's an individual who is at the higher level, either a physician's assistant or a nurse practitioner, who is just taking an oral recap and asking some questions. There may be a nurse who's standing, by the arm, taking some blood pressure, taking a temperature, etc. So you're going to have some activity and some commotion for a short period of time. This may be a great time to remind everybody, quietly behind the scenes, my mother has significant confusion. Please, why don't you send the direction of the questions to me? I can help you better. Mom won't be able to answer that, etc. Without letting mom be too insulted or abbreviated from her position in this, but make sure that you're a part of that assessment if you're able to be a part of that assessment and share that information. There's going to be a myriad of tests and some lab work, and they will do some of the standard operating procedures just to check the boxes. And you may get frustrated with, we know for a fact that it's not a urinary tract infection. Why do you have to get a urine sample? She can't urinate on command, so it means a straight cath. Oh, you guys aren't listening. But guys, they really have to be thorough and do all of these preliminary exams and tests, etc., so that they can make sure that they're making the best assessment ever. Remember, as a clear example, urinary tract infections for our seniors don't really present at times with a lot of symptoms. They typically do not get a fever. They may not articulate discomfort when urinating. They may not even be able to articulate a sense of urgency or a lack of urgency to urinate. And yet there sits a urinary tract infection. So really critical that we let the team do the job they are to do. And then, yes, we hurry up and wait. And I know that that's very, very frustrating. Now, you may wait in the back in a bed. You may be actually sent back out to chairs to wait because they may find that that's the most appropriate scenario for you. You may be sent to a lab. You may be to do a little bit of lab work, etc. Pardon me, but be prepared. And let's have a little gentleness with that if we can, maybe a little humor. I try to remind all of our clients, all our patients, here we go. We're in the hurry up and wait mode, guys. Be prepared. And that's when I try to start that distracting of some sort and trying to keep them calm. Sometimes, we are encouraging, Mom, go ahead, close your eyes and rest. It's a good time to get some rest. And you sit there quietly. That's when you get that sip of water, or you may open that book. You're not dismissing them. You're just trying to get through what will be a hurry up and wait moment or hour, etc. So a diagnosis hopefully comes at this point, and then subsequently a treatment plan. And this could be articulated again by a number of different professionals in the setting that you're in. It may be the doctor actually coming in. Of course, the doctor always comes in at the moment when you think, I think I'll sneak out and go to the restroom, and in comes the doctor. So it's a very nerve-wracking time waiting for that doctor to ultimately come in. We don't have any warning or any sense of timing, and that's so very frustrating. So, if you're able to stay and really get, a good sense of being able to communicate with that team, that's really good. Stay planted if you can. And if not, find a nurse and let them know, hey, I'm going to run and use the restroom. I don't want to miss the doctor. Please talk to me. You'll get this diagnosis and you'll get a sense of what they're going to be able to do here and now in the moment. Or if there are, based on the diagnosis, they're able to give you a new prescription and you're capable of going home, etc. So this is a time when you really want to have all ears open, all eyes open, really trying to get an answer as to what the diagnosis and or treatment plan might be. Don't be shy to say, I don't understand that. That's new to me. We've had this before. Why is it happening again? Is there a way to prevent this? Why is this happening repeatedly? I don't understand. Can you break that down into human terms? Because I'm not a medical individual. So it's okay to say, wait a minute, let's stop for a minute. That's very familiar to you. It's very unfamiliar to me. So can you give me a moment and answer some questions for me? They may, as a result, be telling you that there's an admission or there's a discharge to home. What do both of those look like? If it's an admission, what should I be concerned about? If it's a discharge to home, what should I be concerned about? What does it mean to discharge to home? If you're living in a facility, it's quite different. They need some very concrete written directions on any new diagnosis or any change of medication. So just saying, oh, she's got a little bump to the forehead, go pick her up some Tylenol, take that every couple of hours and you'll feel better, will not do for the facility. So it's making sure that you get clear, concise direction if the discharge is going to be to home or to a facility, or clear, concise directions on what admission looks like. Because at this point, there is a whole new shift in the personnel that are managing you, location of where you'll be, and who will be the care support team as you go through this admission. You may be given some test results at this point. I'm a huge firm believer in, could you print that out for me? Oh, yeah, well, I just told you what it was. You can go in your portal and see what that looks like. I know we're very technology savvy, but I'll be honest with you, I'm of a generation that is less savvy than you younger folks and some of you competent older folks like me. I like things in writing. I think our loved ones like things in writing so they can refer back to those discharge paperwork. So don't be shy about asking for things in writing and asking for test results in writing. What did her blood work look like? What did his blood sugar? Tell me a little bit about that. I'd love to see it in writing. So we'll have something to present when we get ready to go to the doctor with our follow-up visit from this. So important and okay to be particular about that. With either admission or discharge to home, you should always follow up with your primary care physician. First and foremost, notify them of a visit. If you're able to stay in the medical delivery system that you're engaged in, they will actually already be informed and they'll have a recap of it. They may want to see you, they may not want to see you. Because they have the recap, they may be able to do this over the phone. But it's really important to let your primary care physician know that there's been an emergent visit and this was the outcome. Do you need to see them? Do we add this to the litany of concerns that we have? What are their thoughts and what are their issues in that regard? So again, there's quite a bit that you want to go through here, and it's just fine to slow the system down just a little bit and ask for the things that make you feel more comfortable as it might be. All the while, if you are being discharged or they are being admitted at this point, ask for that original paperwork that you provided them. Ask for it back so you don't walk out leaving your critical paperwork with them, because at this point they don't need it. They're done with it. So what if you are going to stay in the hospital? Will you be admitted for formal admission, or are you going to be admitted under the title or the moniker of an observation? And these are two very different parameters, particularly with Medicare. Also with regular insurance, but particularly with Medicare. Formal admission typically means that your insurance will now kick in and immediately go into action. Observation may mean that they are not clear on what your diagnosis is. They're uncomfortable discharging you and sending you home, but they're not quite comfortable admitting you as well. And there's quite possibly the opportunity that if you leave under the observation category, ultimately, that insurance may decline the stay. So again, very, very important to have an understanding of, is this a formal admission or is there an observation status? If it is an observation status, you want a little bit more information. Why are we observing? What are we uncertain of? What are we looking for? And will it turn into an admission at some point? And if not, why not? And will there be coverage with insurance? And we're always happy to walk you through these questions and these concerns at any point if you're not getting the answers that you want. If there is an admission, we have a whole new medical team. And so the answers may, or excuse me, the questions may start again and the answers may be necessary. You may have to fill in the blank. Hopefully there'll be fewer questions, or fewer repetitive questions, but be prepared. Once we get into a bed, the nurse that is now admitting you and setting you up for care in your admission may start all over with, let's go over the med list. Let's talk about the other diagnoses, etc. Try to be patient. Again, they're just trying to set up a good system and make sure that your loved one gets the attention. But this is a whole new medical team. We have ER doctors, we have hospitalists, we have intensivists. In our hospital system, you may be carrying over into all of these genres and all of these worlds. So be prepared. There will be lots of faces, new faces in front of you. And it may be, again, this opportunity for you to calm and quell your loved one. Why are so many people coming in? I just want to rest, or I've never seen so many people in all my life. Reassure your loved one that these are all individuals interested in their well-being and trying to gather all the information they can so they can make the best treatment plan and get them in and out of the hospital in the shortest amount of time possible. At this time, I think it's very important to try to clarify treatment. I think oftentimes we find that they're not quite sure what the treatment is. They know there's a concern. They know the team in the hospital knows there's a validating element to admission, but where do we go from here? What are we treating and what should we try to treat? What will work, what won't work? It's a little bit of a hit and miss at times. They may go the typical route and try all the normal options for the diagnoses that they make, but sometimes those don't work. And so there's a little bit of manipulation and punting that goes on. Be flexible with that, but with each step, clarify what the treatment goals are and make sure that you feel comfortable with those treatment goals, and that there seems to be some method to this madness, as it might be. I think typically there is, but it's articulating that treatment plan so that you can reassure your loved one, this is happening because, and this is what's necessary to get you through this visit and this stay. So you're feeling better, we can get back home. And I think at this point, it really does require ongoing advocacy, ongoing communication. Docs tend to round early in the morning, but not always. So, is that your best time to visit? It may not be your loved one's best time, but that may be the best time to visit. It's not wrong to ask that when you arrive, if the hospitalist or the intensivist has been ready to visit, could you get a synopsis of the visit? Would they have time to round again and just stop by and give you their, brief scenario of what they experienced, what they saw, what they're concerned about, or try to get that from the nurse? This is your chance to say, but I am really the advocate here, and I just want to know the cohesive game plan of what's going on so I can better inform my loved one. So keep that advocacy going. I think it's really critical and important for their success during this hospitalization. When we have dementia in this clinical setting, it gets tougher and tougher, definitely. And so you want to inform the staff as much as possible of the limitations that your loved one might have. I'm a huge proponent of doing this privately, doing it with the greatest amount of respect and translucence as possible. I think the last thing you want to do is walk in and say, okay, here's the deal. My mom has dementia. Don't talk to her, talk to me. Let's try to pull staff aside and let them know my mom has some confusion. And out of respect for her, please please acknowledge my presence. I can answer some questions. Or my mom has some confusion, but she really likes to be a part and feel a part of the decision making. Establishing eye contact with her periodically really makes her feel assured that she's part of this program. So again, trying to make sure that you inform the staff regarding any limitations that you have concerns about. Control the environment as best you can. A lot of stimulation for our cognitively challenged individuals is overwhelming. Sometimes we need a lot of stimulation in the ER visit. There may be a need for 4 or 5 personnel to be in the room at a given time to contend with the emergent situation. But if you can control the environment, turn the lights off as people leave. Close the doors, get the music playing that might calm an individual. See if you can't control that environment. Keep the individual warm and toasty or cooled off if they're always warm and toasty. I think our nursing team and our emergency personnel are so busy. We can be the one to try to calm that and quell that and control that environment so that our loved one, we know them best. We know their history. I had a client one time who was hospitalized for a very long time for very extreme measures, and she was fully legally blind, hard of hearing. And one of her major requests, and it just seemed so simple, was to please announce yourself when you walk in the room. I'm hard of hearing a little bit. I don't always hear the curtain move or the door open. Tell me that you're coming in. Hi, it's Gail. I'm your nurse today, and I'm here to give you your medication. Just tell me that. And please call me by my name. I'm Susan. Please say, hi, Susan, it's Gail. I'm your nurse, and I'm going to bring you your medication. I will be putty in your hands if you will do that for me. Many times we put a sign right outside the door at the entrance of the door, reminding personnel, Susan is blind and hard of hearing. Please announce yourself, tell her your name, tell her what you're doing, and call her by her name. And she'll be putty in your hands. It'll all go better. If you march in and don't tell her anything and she is taken aback by your arrival, it's not going to go well. So let's try to control the environment and remind the staff of what your loved one's needs might be. I don't think it's too much to ask that they try to follow some of this. And we put a cheat sheet right out front of the door. All you had to do was look up and say, oh, point taken, point taken, point taken. Hi, Susan, I'm Gail. I'm your nurse. I'm going to give you your medication. Really made things go much more smoothly. And if things are not going well, or you think there's something that can be done better, or you want some guidance, asking for help is really good. Our nurses tell us that, again, they just appreciate being asked in a civil, calm, non-emotional way. What are you doing? Why are we doing that for my mom? I'm so confused. We didn't do that last time. We should have done that last time. Oh, boy, this is a breath of fresh air. So asking for some help, asking for some guidance, asking questions, and particularly reminding when there's dementia of how it goes best for your loved one will really make the process. And I think the emergency personnel and the hospital personnel make this experience go better for everyone. And that's our goal, certainly, is to make it better for everyone. So let's say you are discharged from the emergency room. Again, I would say gather those test results. I prefer them in writing because I'm old school, but if you can handle your portal, then you go for it. Find out what type of follow-up care might be necessary. Will there be extra hands needed? Will you need to stop at the pharmacy to pick up the medication? Or is it okay to go home because they just had a round of the medication and then get your loved one settled and then go back to the pharmacy and get the medication? If you have a loved one in a facility, are there signed medication orders? I'll never forget, I was with a client who did not have a demonstrative issue. We did not need admission to the hospital, but she had tripped over a little something in her facility room, and she had a pretty nasty skin tear, enough to kind of turn my tummy and make me feel like, oh, that has just got to hurt. And so they attended to it. They did very, very well with it. They looked at the wound, they treated it, they gave us some guidance. All the while, my client, who was very confused, wondered if those cute boys that brought her to the emergency room were going to take her back to her home. That was her greatest concern, not the huge skin tear on her knee or on her shin. They kept telling me that I was concerned about pain relief. I think eventually, even though she was pretty confused, she was going to feel the tenderness of that skin tear. And so I kept saying, you know, we'll need some direction on pain relief. Oh yeah, you just go to the pharmacy, you just get Tylenol. Oh, she'll be good every 6 hours. I know that, but I need it in writing because the facility cannot do anything for her in that regard unless they have doctor's orders in writing specifying how frequently, how often, what volume, and have a signature from the doctor. The nurse got it. And so she went to the doctor, and the doctor's response to the nurse was, oh yeah, that'll be on the discharge paper. Nope, no problem, go. I had to ask 4 times, please, I need it in writing. It's not acceptable to just have a discharge order. I need the prescription in writing with the doctor's signature. I think I was a pest, but I knew that my client could get back to her facility and get the pain relief that she deserved and she earned as a result of the skin tear. So being a good advocate, pleasant, firm, professional, loving, but get those signed medication orders, particularly if going back to a facility. Get a good understanding of the script, the new script that might be coming your way. Is it contraindicated? That's why you have that current medication list, so you can make sure it's not contraindicated with any of their other medications that they're on. And your pharmacist can help you with that if you are unable to get that clarification from the emergency room, as it might be. Pharmacists went to school to understand the medications. Doctors went to school to order the medications. So we often have a little bit of a disconnect there. Your pharmacist can be very helpful as well as your doctors. And then maybe you need some help, additional hands at home. Should she go home or should he go home alone, which is where they might have been prior to this incident? You want to evaluate what additional needs might we have at home and see if you can get some discussion with the emergency room personnel as to what the next steps might be in that regard. If you're discharged, if you are actually admitted to the hospital, then there may be a discharge, there should be, heaven forbid, a discharge home from the hospital. What does home look like? You are going to immediately be working with what is referred to as a discharge planner. So you're going to want to, I would suggest day one, try to find out who the discharge planner is. Believe it or not, guys, the minute someone is admitted, the discharge planner is alerted because it's their turn to start working on what that discharge might look like. They don't have necessarily a time frame in mind, but they certainly are you're on their radar now, and you don't want any surprises. So working closely with that discharge planner will be very, very important because they are the ones who will make the accommodations based on the treatment plan, based on the diagnosis, based on the experience and the time that's been had at the hospital. Will you need additional durable medical equipment, from walkers to wheelchairs to bedside commode to a bedside table to a hospital bed? The discharge planner will be the one that's going to work with you on that and assist you through that process. Much of the durable medical equipment comes to you thanks to Medicare. If there is criteria met to justify that durable medical equipment, and that's where the discharge planner can be of great value to you. So I encourage you to work with that discharge planner. Will there be a rehabilitative stay? Did you meet criteria to then turn to a skilled nursing facility stay, which is where all our rehabilitative efforts nowadays go on? They really don't occur in the hospital. You may see a physical therapist on periodically for a brief assessment in the hospital, but you will not receive ongoing physical therapy pursuant to Medicare and its coverage. So again, we want to find out, will we be going to that skilled nursing facility, and what does that look like? And how do we do that? How do we make choices? This, again, I refer you back to the discharge planner who will help you work through that rehabilitative choice and that experience as it might be. Will you be discharged with home health services to follow up for wound care, for medication management, etc.? Again, your discharge planner will be very helpful in alerting you to what are we going to get as an experience with home health, and how much can we expect? Can we anticipate? How far can they go? Let me assure you guys that home health services are going to be very minimal, very limited. Doesn't mean they're going to send someone out to sit with your loved one for hours and hours. They may send a nurse out to see how the wound is doing, and that nurse may end up spending 30 to 40 minutes with you for 4 or 5 visits, and then you're discharged from the services. So get clarification on what rehabilitation, what home health might look like, what the duration of the stays might be, and how do you navigate that from that point on. And then will there be supplemental care? Will there be a need for extra hands now that the circumstances have changed for your loved one? So again, a discussion of, do we need to look for family assistance, informal support? Do we need to look for agency caregiver support? Will there be anything available from maybe their long-term care policies? Will there be any follow-up from their from the hospital to their home? And if we don't feel that we're comfortable managing their new diagnosis and their new care, where do we turn? How do we get someone engaged to come to the home and do an assessment, or come to the hospital and do an assessment and determine whether we need that supplemental care? So very helpful to try to get some clarification on that discharge. It's a complicated transaction, no doubt, and really important to get the good information that you might need and you would value as you discharge from the hospital. It's all very complicated at this stage. And I know all of you, by nature of the fact that you want to be here and you're listening to this, you're trying to get good information to make sure that you make this experience as positive and productive as possible. So who pays for what? Insurance and co-pays come into play. Medicare, your primary insurance will be the primary driver in all of this. Your supplemental insurance will be engaged in it as well. This is why you're asked to bring insurance cards, supplemental cards, all kinds of information when you come to the hospital, should there be an admission. So it's important to have that material available. Do you meet criteria for a rehabilitative stay in skilled nursing? Typically, a criteria is an event that brings you to the hospital, 3 consecutive nights in the hospital attending to that event, and then an evaluation from the medical personnel that says that you are eligible and capable of recovery from this event, and that recovery would occur as a result of time in a skilled nursing facility to do the rehabilitative components: physical therapy, speech therapy, occupational therapy, getting you back to baseline or back to who you were prior to that event that occurred that brought you to the hospital, as it might be. You will see differing opinions on whether you meet criteria in this regard. So this is much driven behind the scenes by insurance and Medicare, just pushing and saying yes or no, and having pretty severe boundaries in regards to qualification for this, this category. So there may be a desire to appeal a discharge. No, she's not ready to come home. No, we're not prepared. There is a formal procedure. We're happy to help you through that or talk you through that experience. I won't take the time now as I'm running a little long here, but you can appeal the decisions. You need to, again, immediately let your discharge planner know that we do not agree because we have these following concerns. We'd like an appeal. How does that process work? And let's get moving on it. I think the biggest issue and the biggest criteria or biggest bullet point that I wish we could make it quite large is that last bullet point that says, have a plan B. Have a backup plan. Think through these potentials and know that it's really important if things are not working. well, or you're getting information that is new and this is all overwhelming to you, have a plan A, have a plan B, and I would even say today have a plan C. Line up that in-home care before these incidents happen. Understand your medical insurance coverage. Understand what the facility, if your loved one's in a facility, how far can they go with you if your status changes and your care plan needs to be updated. What can the family do? Who's got time to be an additional extra set of hands when life gets pretty complicated in this scenario with your loved one? So plan B is always good. We're huge believers that you plan ahead anyway. I don't have a crystal ball. I can't tell you what your exact journey might be, but I can tell you if this happens, this is a suggested resolution to the problem. If this happens, here's a suggested resolution to the concern. Having some plans in place will make this far less stressful. And again, remember, we're in that crisis already with this pandemic. So not having any iota of a backup plan is going to put you into a tertiary crisis level, from pandemic to emergency room and or hospital visit. And then we don't have a clue. We don't know what to do. And this is all coming at us really fast and furiously. It's familiar to me. And I have a loved one who unfortunately has a lot of hospitalizations. And I find with each of her hospitalization, I learn something new every time. So I think I'm a pretty seasoned individual in this experience, and even I have some traumas along the way. So important to have that plan B in place. Well, to that end, we've completed the presentation today for what it might be. I'm going to silence myself for a minute, hand this back over to Maureen, and see if there's some questions that we might answer. I want to thank you all for joining us. I want to thank you all for being so proactive and gaining hopefully some good tidbits and some good information regarding a hospital or emergency room visit. I hope we've made a difference and added, if nothing else, just one element to your toolbox that you may have in place already and made your life just a little bit easier should something like this arise for you. So Maureen, I will hand it back to you and say thank you.
Thank you so much, Gail, for all that information. Definitely help prepare us better for upcoming emergency room visits that hopefully we don't have to face, but if we do, we know how to approach those. So a few questions here for you. The first being, how does one know when the situation warrants a visit to the emergency room or the urgent care center? How do you decipher between those two?
I think that's a really, really good question. And unless you're a medical person, I think that, that's a tough one to answer in many ways. Again, I think if you have these very extreme outliers, high temps, cognitive issues that turn on a dime, a fracture that might, you've got such unmitigated discomfort that you're hearing from your loved one. The urgent care is probably going to move you along quite quickly to a hospital. I recall one time my daughter, who has some medical issues, came home from a week at Mayo Clinic, walked in the door and promptly began vomiting, unfortunately. And so naively, let's get you to the urgent care. We walked into the urgent care and they looked at us in a nanosecond and said, "Are you kidding? You need to be at the hospital. We're calling the hospital right now to say you're on your way." So again, a little naive. We had hoped a week at the Mayo Clinic would be a benefit for her. And I think we were just naive thinking, oh, this will remedy itself. So again, look at the emergency of it, the urgency of it, the severity of it. Our urgent cares are wonderful. If you're thinking that maybe you might have COVID and you'd like to be tested, maybe an urgent care that does testing would be fine. If you don't have extreme symptoms, if you have extreme symptoms of any nature, then let's get to the emergency room. I think it's a bit of a decision, a bit of a judgment call. But again, look at the severity of the symptoms and what you're comfortable with and move it along accordingly.
Thank you. Another question here. Does the pulse need to be visible in the home if they have selected attempt resuscitation or CPR is indicated? Isn't this the standard process for EMTs upon arrival? And also is a copy of the pulse sufficient, or does it need to be the original?
Excellent suggestions or questions there. The original is not necessary. It's ideal and most desired, but it's not necessary. If you have a copy that's legible and readable and it's signed by the doctor, absolutely acceptable. I would keep it in, a visible place is good. But again, if I live alone and I'm not able to speak for myself, how am I going to be able to tell the emergency personnel, oh, it's in the third cabinet on the upper set of cabinets next to the dishwasher, just open the door, you'll see it. I won't be able to do that. So hanging on the refrigerator is most desired, but I think you'll find our emergency personnel are they're pretty dogged. They tend to split. Half of them go to the client or to the patient, half of them go into that kitchen to desperately look for your packet of information. And the post is beneficial even if you are a full code, because you have, if you take a close look at that post, you'll see that there may be some limits to the extreme attention that you want, i.e., yes, give me oxygen, but don't throw me on the ground and give me full-blown compressions. Or I'm trying to think of another good example. If you want a respirator or feeding tube, well, they wouldn't do a feeding tube in an emergent person circumstance like that, but a respirator or air functioning for you, you can, on the post, you can make some limited determinations on how extreme you want that care to be. So if the post is not present, you can be doggone sure, if there's no indications, and no emergency personnel is going to take 10 minutes to flip through your advanced health directive, which is 6 to 7 pages long, and try to read it and discern. They are going to put you on the ground. They are going to do every extreme measure known to keep you alive, because that's what their job is. That's what they're hired for. That's what they are coming for. They are coming because you've contacted them and you want their expertise. So if without direction, big direction, limited direction, etc., from a formal document like a post or an advanced healthcare directive, they're going to do their job, and they should. And so that's a positive, I think, in many ways. So look at that post. I think you'll find it's beneficial one way or another.
Thank you. One last question here for you. If you go in an ambulance to the hospital and don't see the bill, how do you find out if it's covered or if the bill is just still coming to you?
That's a very, very good question. There's been a lot of discussion about that of late. If you don't see the bill, I think you should be very comfortable assuming that your insurance has seen the transport as a approved transport. This is, again, insurance driving this issue and this qualification, and so it is covered by your primary and your supplement. If you want a copy of the bill to see what it looks like, to see what the charges might be, you certainly can request that through Medicare or your primary, if you're not on Medicare, through your primary insurance coverage. If you do see the bill and you want to debate the bill, you actually have that right as well to deem that it was an emergency and it was necessary. You don't have to be admitted for that transport to be deemed an emergency. At the moment, it was deemed an emergency, and this is why, and the resolution was such that you were either remedied and sent back home, or you were admitted as a result. So that's a very, very fair question. I hope I've answered that for you. If you don't see the bill, it has been essentially, again, approved and passed through the system. If you do see the bill, you have the right to dispute it and try to get further coverage of it. And thirdly, if you want to see the bill, you have the right to ask to see how was that handled from your insurance company, be it primary Medicare or primary private insurance.
Fantastic. Thank you so much. At this time, we are going to thank Gail so much for all the information she has shared. And also, we would like to thank each of you for joining us today. If you still have questions that are pending, please feel free to contact us. This is our contact information here on the screen. As you can see, Gail is a wealth of knowledge and is happy to help navigate a circumstance. If you're looking for some information on a specific situation, she's happy to field a phone call with you and help you try to get some answers. And with that, I would like to switch to our slide that will show you a little bit about who we are, what Elder Care Management does. Elder Care Management is a locally owned care management company, and we have a team of care managers here to help advocate for individuals navigating the aging process, maybe finding some obstacles, a new diagnosis, a crisis situation, and they just need help finding a path moving forward. We are 24/7 support for our clients in crisis situations. So when our client has an emergency room visit at 2 a.m. on a Saturday morning, which it always seems to happen in the middle of the night and on a weekend, if you have had these experiences happen to you, one of our care managers will be at the emergency room with our client to help them navigate through that process. So this can be a great support, even for individuals living in a senior living community where oftentimes they don't have the staff to send to the emergency room and then sit in the emergency room for 6 hours. So especially if there's not local family nearby. We do have the ability to just do a one-time assessment if a family just needs a care plan to help them move forward on next steps, help get all these different pieces in place, that plan in place. We're happy to do that, or we can do ongoing care management. And we also do medication management. So if an individual needs help filling med boxes, streamlining that medication, if there's need for discussions with physicians as to why there's so many different medications on board, we can help through that process as well. So there's a lot of different ways. It's not a cookie cutter service. The best way to better understand about our services is to visit our website, which you can see there, www.eldercm.com, or feel free to give us a call. Gail is always happy to do a free phone consult, and again, just provide some information. So some ways that we can help you there. We also would like to thank Simone and Del Oro Caregiver Resource Center. You will see shortly there will be a survey that will pop up, and we ask that everyone take the few minutes to fill that survey out. We really want to provide the best educational opportunities we can to the community and want to make sure that we get your feedback so we know how to improve areas that we can add to, or things that you do like or don't like. So please make sure to fill out that survey so we can get that feedback. With that, I would like to switch it over to Simone so she can share with you about the Del Oro Caregiver Resource Center. Thank you.
Thank you so much, Maureen and Gail. I always feel like I learn something new when you give this presentation. I just appreciate how much knowledge you can offer, and how much insight you can give us into navigating ERs and hospitals in this new landscape that we're living in, because it certainly is different than before the pandemic. So thank you again to Gail, our speaker. Thank you to Maureen. Just a really quick note about Del Oro before we end for today. Del Oro Caregiver Resource Center has the pleasure of being able to collaborate with community partners like Elder Care Management to offer education, free education to family caregivers and the general public. Del Oro exists to improve the well-being of family caregivers and provide support throughout the caregiving process. We're actually part of a statewide system of 11 CRCs, and we happen to serve California's Gold Country counties in Northern California. All of our services are free, and these would include information referral, support groups. We maintain a list of local support groups, and we offer a few in-house as well. Education and training like today's program. But we also offer more specialized, or I should say direct services to clients who meet eligibility. And these include family consultation, sometimes case management, respite care, which is a big one. You know, we understand that caregivers need support, that they need someone to give them a break occasionally so they don't burn out. So we contract with local care agencies to provide that support, local adult day programs. We also offer short-term counseling to caregivers, as well as legal consultation. Again, all of these services are free, and we are here to help. If you have any questions for us, please check us out online. We're on social media. We also have a great website at www.deloro.org, or you can give us a call at 916-728-9333 to talk to somebody and see if you might be eligible to become a client if you're not already one. Thank you again so much